Good evening to everyone. Today we are going to have a discussion on endoscopy in pregnancy. Myself, Dr. Aneesh, consultant gastroenterologist and hepatologist from Imperial Hospital, Bhimavaram. So, as Madam has already given my introduction, so I belong to Tadepalligudem. I did my MBBS and MD medicine from Andhra Medical College, Visakhapatnam. I did my DM Gastro from G.P. Hospital. I did fellowship in endoscopic ultrasound and in third space endoscopy, especially on POEM. My field of interests are ERCP and endoscopic ultrasound. So coming to our topic, so our topic is endoscopy in pregnancy. So we all know performing endoscopy in a normal general population is a relatively safe procedure. However, performing endoscopy in pregnancy has its own risks. So the risks are, first one is maternal oversedation. So some procedures like ERCP and some therapeutic endoscopy procedures require sedation. Maternal oversedation can lead to hypoventilation, hypotension, hypoxia, which can cause fetal distress. Number one. Number two is placing the pregnant female, especially in second and third trimesters, in semi-prone or in supine position can cause compression of the aorta or IVC by the gravid uterus, leading to decreased placental perfusion and again fetal distress. Number three is teratogenicity associated with the drugs used for sedation and the radiation exposure that will be exposed during the ERCP. Number three is deep intestinal intubation can sometimes trigger premature labor and sometimes can also cause abruption of placenta, and again the high risk of aspiration in the pregnant female. So considering all these risks, endoscopy in pregnancy should be done only if the indication is clear and strong, number one. Number two, should be done only by an experienced endoscopist and should be done in an institution where both obstetric and neonatal care are readily available. So I will discuss my topic in two parts. First I will discuss ERCP in pregnancy and then I will go to endoscopy in pregnancy. So let's start with the case scenario. The 19-year-old female, she's preemie with 2 months period of gestation. She presented with right upper quadrant pain, jaundice and fever. Her lab parameters showed elevated TLC of 13,000 with thrombocytopenia and bilirubin was 8.6 with ALP of 611, suggestive of cholestatic pattern of jaundice. And ultrasound showed IHBRD with gallstones and CBD stones, making a diagnosis of CBD stone with cholangitis. So what is the next line of management in this patient? Option number one, either you manage medically as she is in first trimester. Number two, immediately do the ERCP, or number three is manage conservatively now and then do ERCP in second trimester. So let's see what is the best option for her. So American Society of Gastroenterology Endoscopy and American Gastroenterology Association guidelines have proposed that whenever a patient is having acute cholangitis, like as in our case, she should be subjected to immediately ERCP irrespective of period of gestation. And a patient with biliary pancreatitis with suspected impacted stone at the ampulla should be subjected immediately to ERCP irrespective of period of gestation. Elective indication is symptomatic CBD stone, like stone causing mild jaundice or causing pain. And what is the ideal timing for ERCP in pregnancy? If the indication is urgent, like as cholangitis or pancreatitis due to CBD stone, should be performed immediately irrespective of the gestational age. If the indication is elective, like symptomatic CBD stone causing mild pain or causing mild jaundice, we can defer the procedure till second trimester. Even lab chole can be done safely throughout the pregnancy, preferred in second trimester. So we all know ERCP will be done under sedation. So what drugs are safe to be used in performing ERCP during pregnancy? So we all know FDA has divided the drugs into A, B and C. There are no category A drugs that can be given for sedation in pregnancy. So our main motto is to give moderate sedation and to give the least effective dose of the sedation. So we always prefer category B drugs. In clinical practice, the most common used drug is propofol. If propofol is not sufficient, we can go for midazolam or ketamine. And American guidelines propose that meperidine can also be used as a drug of choice for sedation in pregnancy. And rectal indomethacin will generally before ERCP will give this indomethacin suppository for all patients to decrease risk of pancreatitis. It is also a category C drug. So checklist before ERCP. So you should take consent from the patient. You check whether the indication is clear and strong or not, and explain the benefits and risks of the procedure to the patient, and also explain the maternal and fetal risks of the procedure. So before performing any endoscopic procedure in a pregnant female, obstetric consultation is always mandatory regardless of the period of gestation. and this should be preferably done in an institution where obstetric and neonatal care are readily available, especially if the gestation age is more than 24 weeks. If the gestation is less than 24 weeks, we should check the fetal heart rate just before the giving sedation and after completion of the procedure by handheld Doppler. If the gestation is more than 24 weeks, we need to put a continuous fetal heart rate monitoring and uterine contraction monitoring before the procedure, during and after the procedure. So what is the ideal position for performing ERCP in a pregnant female? Normally we do ERCP in prone position. If the patient is in first trimester, we can do in prone position. If she is in second trimester or in third trimester, we do in semi-prone or in left lateral position. This will avoid the compression of the IVC or aorta by the gravid uterus. So we all know ERCP involves cautery for sphincterotomy. So while using cautery, the currents may get transmitted to the amniotic fluid and to the baby. So to avoid the transmission of the current to the baby, either use a bipolar cautery. If bipolar cautery is not available, you can use monopolar cautery. But you should put the grounding pad either on the shoulder or on the arm, not on the thighs. If you put the grounding pad on the thighs, the current may transmit to the baby through the amniotic fluid. So coming to the procedural aspects, most of the endoscopists will follow a two-stage approach. Means generally in first step we do the ERCP completely by turning off the fluoroscopy machine. We go into the duodenum, we identify the papilla, we cannulate the CBD, we aspirate the bile and confirm that the sphincterotomy is in the bile duct, and then we do sphincterotomy and put a stent. After the procedure, we do an ultrasound and confirm that stent is in CBD. And so we'll do this procedure in the pregnancy part, and once she gets delivered, 4 weeks after delivery, we do the CBD clearance. But the disadvantage with this approach is we are not sure whether the guide wire is in the gallbladder or in the bile duct. Number one. Number two is if there is impacted stone in the upper CBD, we are not sure our stent is beyond the impacted stone or not. And number three is as the CBD stones are not cleared in the patient, so the patient stents might get blocked early. So she might need repeat interventions in the pregnancy part. So some endoscopists prefer to do complete CBD clearance in one setting with minimal usage of fluoroscopy. So coming to the radiation exposure in the ERCP, American College of Obstetricians and Gynecologists have proposed that exposure up to a 50 microgyrons do not cause any congenital malformations and do not cause any adverse effects on pregnancy to the mother or to the baby. And majority of the effects do occur at a dose of 100 microgyrons, and maximum risk is during 2nd to 15 weeks. So how to reduce the exposure, how to reduce the radiation exposure during the ERCP? So instead of pressing continuous fluoro, you can use short taps of fluoroscopy and avoid taking hard copy images like as shown in the picture in the side, and use the last hold image feature to review the previous images, and you can use a drape sheet around the fluoroscopy machine to reduce the scatter of the radiation. So Dr. Chalapatirav Vachanta, he is a gastroenterologist from KIMS Hospital, Visakhapatnam. He described a radiation-free removal of CBD stones in pregnancy by EUS and single operator cholangioscope. Basically what he did is he initially did an endoscopic ultrasound before performing ERCP. He made a record of number, size and location of stones, and he did ERCP, and he removed the CBD stones as much as he can, and then he took a cholangioscope into the bile duct and he made sure that the bile duct was completely cleared. So this technique does not involve any radiation, and in single setting complete CBD clearance can be done. So let's see what the literature tells, how safe is performing ERCP in pregnancy. So this study involves 68 ERCP patients of pregnant females. Majority were done in the third trimester and 50% were done in first and second trimesters. Most common indication being abdominal pain followed by jaundice and cholangitis. So if you can see the total fluoroscopy time, the total fluoroscopy time is about 1.45 minutes only during the whole procedure, and with this minimal exposure time they are able to do 100% biliary cannulation in all the patients, and they are also able to achieve 97% CBD stone clearance in all the patients. And if you see the complications, none of them had perforation, none of them had bleeding or oversedation, but 15% of them had pancreatitis, majority being mild. All are managed conservatively. Coming to the feto-maternal outcomes, we can see none of them had fatal malformations, none had perinatal death and stillbirths. However, low birth weight rates and preterm delivery rates are higher in those who underwent ERCP in first trimester. The reason for this is exactly not known, but this study concludes that ERCP in pregnancy, whenever it is indicated, can be done safely without any major adverse effects to the mother and to the baby, and we can and by minimal usage of fluoroscopy we can completely clear the CBD and put a stent also. So this is a study from my institution, G. Pant Hospital. So in the last 10 years we did 30 ERCPs in pregnant patients, and the most common indication being CBD stone, and the most common indication being CBD stone 90%, and symptoms are pain, jaundice and cholangitis. We can see 40% are in first trimester, 30% in second trimester and 30% in third trimester. In all the patients we are able to achieve the biliary cannulation, we are able to do CBD clearance also with minimal usage of fluoroscopy. So now we have completed the ERCP part. Coming to the endoscopy part. So we all know the most common indication of endoscopy in pregnancy is GI bleed. If it is upper GI bleed, we'll do upper GI endoscopy. If it is lower GI bleed, we'll go for lower GI endoscopy. And other indications include dysphagia with significant weight loss, suspicion of GI malignancy, persistent diarrhea or a flare of IBD. So we all know majority of pregnant females report symptoms of GERD, symptoms of constipation, symptoms of hyperemesis gravidarum, but performing endoscopy in these patients does not change the treatment. Hence endoscopy is not indicated in this group of patients unless otherwise you suspect some organic cause of the symptoms. And the contraindications include placental abruption, imminent delivery, ruptured membranes and uncontrolled eclampsia. Therefore all endoscopists, before doing any endoscopy procedure, take an obstetric consultation, check the fetal heart rate is good or not, and make sure there are no contraindications to the procedure. So coming to the safety and efficacy of endoscopy in pregnancy. So in this table I have quoted both Indian studies and Western studies. So we can see that diagnostic endoscopy, diagnostic sigmoidoscopy and EVL and sclerotherapy are done in pregnant patients without any adverse feto-maternal outcomes and with good diagnostic efficacy. We can see the diagnostic yield in upper GI bleed is 95%, and all the therapeutic like sclerotherapy, EVL were successfully done in all the patients. So making that endoscopy procedures, both diagnostic and therapeutic, whenever indicated, can be done safely and they have good efficacy also. So the most common indication for upper GI is the most common indication for endoscopy is upper GI bleed in pregnancy. The most common cause of upper GI bleed is non-variceal bleed followed by variceal bleed. So the most common cause of non-variceal bleed is Mallory stare in 25%, followed by erosive gastritis and peptic ulcer disease. Less common causes include esophagitis and dilation. And the second common cause being variceal bleed. So variceal bleed causes include either extrahepatic portal obstruction and non-cirrhotic portal fibrosis. Cirrhotics are unlikely to become pregnant because of the altered estrogen metabolism. So whenever a pregnant female with a HPV or NCPF becomes pregnant, she should be subjected to endoscopy in second trimester, because in second trimester portal pressure will reach to its peak and 50% of them can have variceal bleed, so that can adversely affect the mother and the baby, and even at the time of the delivery, because of the Valsalva, the mother can have variceal bleed. So that's why all gynecologists should refer a patient with HPV and NCPF to endoscopy in second trimester. If there are large varices, we will be doing EVL, and if there are small varices, we will do either beta blockers or we will keep them in follow-up. Unfortunately, if a patient bleeds she presents with variceal bleed, we will restrict the patient, give antibiotics, and we follow restrictive transition protocol, and we should not give terlipressin or vasopressin. The drug of choice is octreotide 50 mg stat followed 50 mg for infusion, and then we'll go for endoscopy. If there are esophageal varices, we will do EVL. The gastric varices, we'll do the glue injection. If endotherapy is failed, then we'll refer the patient for TIPS. So apart from ERCP and diagnostic and therapeutic endoscopy, there are also few case reports of percutaneous endoscopy gastrostomy done in pregnancy, enteroscopies in pregnancy, capsule endoscopies in pregnancy, and botulinum toxin injections for achalasia cardia and pneumatic balloon dilatation for achalasia cardia. So coming back to our case, in our case we gave antibiotics and we did ERCP completely without fluoroscopy. We have put a stent, and after putting the stent we did an ultrasound, confirmed that stent is in the CBD, and we discharged the patient 2 days later. So the take home points would be any endoscopy procedure you should before doing any endoscopy procedure, always take an obstetric consultation irrespective of period of gestation, and check the indication is strong and clear or not. If the indication is non-urgent, defer it to second trimester. Always minimize the procedure time and always use the lowest effective dose of sedatives, preferably category B drugs. And ideal position would be left lateral position for the pregnant female. So just I would like to show some interesting procedures that I performed during my residency. So this is a slide showing for different foreign bodies. So this is a case of a prisoner who consumed a mobile phone wrapped in a polythene bag when he was in the jail. So we did remove this mobile phone and using snare forceps. This also got published in the paper in the Delhi local paper. And this is a video showing this is a young girl who is suffering from psychiatric illness. She is fed out the brush. So we removed this brush using snare forceps. This is the image of the brush after removal from endoscopy. And again, these are different foreign bodies, blunt objects like magnets and some blunt foreign bodies. So this is a young boy who came with nail injection. So we removed this using rat tooth forceps. And this is a case of elderly female. She came with symptoms of iron deficiency anemia. On evaluation, we found a large 5 cm polyp in the fundus. So we did polypectomy using endoloop, and that was sent for histopathology, which was found to have gastrointestinal stromal tumor. And fortunately, the margins are completely free of tumor. So after procedure, she was completely fine. There is no need of any imatinib after the So this is a case of elderly female. He is having multiple gallstones and multiple CBD stones, but due to her comorbidities, she was deferred for surgery. So hence we did an ERCP and removed multiple CBD stones, as we can see in the endoscopic picture. And after doing this CBD clearance, we referred the patient for cholecystectomy. And this is another case of we can see the first image. This is the first image showing this is the ERCP scope, and this is the CBD showing multiple CBD stones. This is a large CBD stone. So we did dilatation of the biliary sphincter. This is the fluoroscopic image, and this is the dilated biliary sphincter on endoscopy. So later on we removed the 2 cm stone from the CBD. This is a post-chole patient. This procedure is called EPLBD. EPLBD means endoscopic papillary large balloon dilatation. And this is the case of pre-cut sphincterotomy. Normally, when the standard cannulation techniques fail, then we'll do a pre-cut to cannulate the CBD. So this is the ampulla. So whenever the standard cannulation has failed, then we'll take a needle knife and we slowly incise the ampulla. Basically, this is the case of CBD stone. Standard cannulation has been failed, so we did take a needle knife and we slowly incised the ampulla to expose the biliary mucosa. So now inside we can see the yellowish biliary mucosa and we can see the opening of the CBD. This is called needle knife papillotomy. So now we cannulated the bile duct. We can see the guide wire going inside into the bile duct. Now we can see the guide wire field going inside. Now we can see the guide wire going field inside into the bile duct. So this is another interesting case. Basically, a 16-year-old girl, she had recurrent history of pancreatitis. On evaluation, she was found to have pancreas divisum. So we subjected her to minor papilla sphincterotomy. So we can see this is the minor papilla. So we incised the minor papilla and we cannulated the pancreatic duct. And we have cut the sphincter of the pancreatic duct to relieve the pressure in the pancreatic duct. And later on we have put a stent in the pancreatic duct. So after putting stent, patient was asymptomatic for 6 months, and she never had any again recurrent episode of pancreatitis. So this fluoroscopy image is showing. So the first image is a case of periampullary carcinoma with gastric obstruction. Patient is unresectable. So to relieve the gastric obstruction, we have put a pyloric metal stent. We can see the stricture. So this is the strictured part. This is the tumor invasion. This is the proximal flange, and this is the distal flange. This is the narrowed area because of the tumor. And this is another case of periampullary carcinoma with biliary stricture. So this is the part in the stent, and this is the distal and proximal flange. We can see the air in the bile. This is the proximal part and this is the distal part. This is narrowed stent. And this is another case of, this basically is a case of acute pancreatitis with symptomatic wall-off necrosis. So basically she is having symptomatic wall-off necrosis. So we have punctured the cyst wall using a cautery enabled lamps, lumen opposing metal stent, and we can see the lamps being deployed. We can see the flower, we can see a flower coming out. We can see a flower coming out. Yes, this is called as lumen opposing metal stent. Now on endoscopic image, on endoscopic view, we can see the free flow of pus coming out from the cyst into the stomach. This is the free flow of pus coming from the cyst into the stomach. So this is the same case. After putting stent also, patient continued to have fever spikes. So we did a necrosectomy for the patient. So after putting stent also, she required multiple, she is symptomatic, she is having continuous fever. So we have entered the cyst cavity using an endoscope. This is the cyst cavity showing a lot of necrosis and debris, and we tried to remove a lot of necrotic debris. We tried to remove the debris from the cyst cavity. So this is a large fistula seen communicating, this is a large fistulous opening between the duodenum and the cyst. This is called as spontaneous cystoduodenostomy. This is called spontaneous cystoduodenostomy. So this whole thing is cyst cavity. There is a lot of debris in the cyst. So we tried to remove the debris from the cyst cavity, and then we flushed the cavity with betadine solution. So after multiple sessions, patient finally recovered and she got discharged. So finally, thanks to all my teachers and thanks to all my seniors, colleagues and juniors, thanks to my endoscopy team for making me who I am today, and I am always grateful to my institution, G.P. Hospital. Thank you.